we call a noon conference is probably what you call a morning report at your site. It's usually some sort of a live patient-based, it's always patient-based, but it's usually a mystery case or something like that. It's a where you go through and talk about clinical reasoning, decision-making. What you might have as noon conference is all the stuff that we took out of that middle of the day and put into our educational half day. And so when you think about all the didactic education, more lecture type things, disease-based things, that's all what lives on the Wednesday educational session. And what used to be at 7 in the morning or 8 in the morning or 9 in the morning and never found a good home because it's busy is now what we do with lunch at the noon hour. So just a little terminology there. I remember when I was a chief, I think my intern year noon conference or morning report was at 7. And then my junior year was at 8 and my senior year was at 10. And then when I was a chief, I was like, hey, why don't we do 9? And like all the program directors slapped their heads and like, it was 9 the year before you got here. So there was never a good way to squeeze that in.
We kept moving morning report when you were a trainee because you kept sleeping in longer and longer.
Dr. Albert, it's good to see you.
I think that is a good intro to start out today. So Dr. Connors just spoke. Dr. Albert also just spoke. Dr. Albert's one of our professors of medicine in the pulmonary department, one of our sort of national and international experts in all things pulmonary disease. And he'll be helping out today as well. So welcome everyone to our Recruitment Day Noon Conference. We are so excited to have you all here. Obviously, we wish it could be in person, but in lieu of that, we're gonna, like Dr. Connors said, do our thing here via Zoom. So just so you guys think that we don't all take ourselves too seriously, I decided to just get to kick this off by embarrassing myself. And that is a photo of me when I was 12 years old on ESPN, losing my mind. Also how I feel when the chai chai Indian food gets delivered on Fridays. So with that being said, I'm gonna kick it over to our residents and let them introduce themselves.
I can start because I'm not muted. One, Danny, you're the manliest 12-year-old I've ever seen in my life. My God. Yeah, my name's Jake. I am originally from Boston, Mass. Went to school in Chicago at Rush Medical. And now I'm lucky enough to be training here in the hospitalist training track with some great colleagues.
Hi, I'm Julia Haynes. I'm from Indiana. I originally grew up in a small town there. Went to Indiana University for medical school, and now I'm happily out here enjoying my first year of internship.
And I'm Yunan. Sorry, I couldn't get the video to work on my phone, but I'm an R2. Parents are in Pittsburgh, so I'm calling that home base. And I went to med school up at Cornell in New York City, but loving it here. Finally got into hiking and skiing.
Awesome. Thank you all. And then I'm Danny. I'm one of our inpatient chief residents, and I will be facilitating today. This is a case that I had from 2 weeks ago, and I was attending at University Wards. So first of all, a big welcome to all of our applicants. Like I said, we are so excited to have you guys here, and we hope the interview day went well. I would treat this noon conference as sort of the reward for interviewing, and just sit back and relax. Don't feel like you need to participate. But if you want to participate, you are more than welcome to. The chat is always open to throw in ideas, thoughts, questions, anything like that. But we're so excited to have you here. So where are you all coming from? Here's a map which shows, we interview people from all over. I think a lot of our residents and interns will attest that our classes basically from all over the country. And we sort of look for that in our recruitment. And so thank you all for virtually traveling here today. The big thing is because you're not here, you are missing what the city looks like. And so I took this picture from our 10th floor of our university hospital this morning, showing basically the Denver skyline and the Rocky Mountains behind it. So we are about 9 miles from downtown, and Denver Health is right there. And so if you come here, you can basically have this view at all times in the hospital, which makes working substantially better. So what is our teaching structure? So in the before times, we did, like Dr. Connor said, a classic noon conference, in person, whiteboards, PowerPoints, and it was fantastic. We've made some changes since COVID started. So now we have a daily virtual conference, which is what you guys are seeing right now. But we're also still doing some in-person stuff in groups of 5 to 10, depending on the site, with social distancing, just to make sure that we keep that part of our mission. And we take all of our daily virtual conferences and we put them onto a pretty active YouTube channel. And so if you guys are interested in checking out things we've done before, so you can see that this is sort of not an aberration in what we do, 4 to 5 days a week, I'd encourage you guys to check it out. My co-chiefs have put together some absolutely amazing conferences this year with the assistance of our interns and residents. So with that being said, we're going to go ahead and kick this thing off and get started. So I'm going to stop sharing and let my co-chief Sneha put up the document. All right. So like I said, this is a case from a couple weeks ago at university that my team took care of. So our chief complaint today is going to be hypoxia. I know Dr. Connors and Dr. Albert are probably thankful that we did something in the pulmonary realm. So our HPI, we've got an 86-year-old man presenting from his PCP office for further evaluation of hypoxia. So his story, for the past 2 to 3 months, he's noticed increased shortness of breath with exertion. Specifically, he states that he feels okay when he's sitting or lying down, but he notices he's short of breath whenever he walks up the stairs in his daughter's house. After first noticing that shortness of breath, he bought a portable pulse ox on Amazon like most of us did during COVID, measured his oxygen saturation and found it was in the 80s. He then began using his wife's oxygen at home for 2 liters per minute. He's been using the oxygen at 2 liters per minute since then. He denies any fevers, chills, chest pain, pleuritic pain, and essentially denies all symptoms. He says he's been able to sleep flat without any shortness of breath or difficulty breathing. And then notably, 1 month prior to his presentation, his PCP got a CAT scan to further evaluate these symptoms and showed what was concerning for a right lower lobe pneumonia. He was treated with antibiotics, but says that his oxygenation or his symptoms did not get any better. On the day of presentation to our hospital, he was seen by his PCP in clinic and found to be 84% on room air and referred to the ED for further evaluation. And Connor brings up a good point. A goal in life should be to find a partner who lets you use their oxygen even when they are hypoxic. All right. And so with that, I will throw it to our discussants. What thoughts do you guys have?
So I guess I can start. My general approach to hypoxia is trying to figure out along what point of the airway is the hypoxia coming from. So is it the oxygen that's coming into the body? Is there a problem with the lung parenchyma causing it? Or is there a problem with exchange, or is the hemoglobin not picking up oxygen? So that's kind of my basic approach, is figuring out where along the body, or kind of the track of air into the body, where it's coming from.
Yeah, I mean, I totally agree with Julia. I think like there's 2 approaches to this. One is your dyspnea pyramid, where you kind of map your way through the lung, and then you consider also cardiac etiologies and some other ones like Julia mentioned, like anemia or like anxiety, deconditioning, stuff like that. And then I think the other way you could approach this is going down your list of like 5 causes of hypoxemia. So starting with decreased FiO2 versus diffusion versus hypoventilation, and VQ mismatch versus shunt. And I think, just based on what we're hearing about this patient already, I would be surprised if it's due to decreased FiO2, if it's due to hypoventilation. So I think we're kind of in that realm, like Julia said, of is this parenchymal? Is it alveolar? Is it a problem with cardiac tissue? So we're in an 86-year-old gentleman, everything is undifferentiated at this point too. So it could be literally anything.
And for me, I think, we always say history is like 80% of the exam. And so I'd like to know a little bit more about his, put him into context. Like, what's his medical history? What does he do socially, especially with our lung pathologies? What are his habits? Who is he around?
Perfect. That was incredible. You guys took a lot of the stuff I was going to say. So I love that approach. So the 5 causes of hypoxia, which Jake hit on, and then Julia put that in even more context and sort of tried to combine it with anatomical stuff, which is absolutely incredible. So based on what you guys said and what Yunan just said, before we get into a little bit more history, if you were putting your money down, Jake said he didn't think this was decreased FiO2. He didn't think this was hypoventilation. Are there any historical clues or anything like that that point you to one of these other causes?
Yeah, I think if I had to put my nickel down immediately, I mean, we have an inciting event. I think, VQ, first of all, the intricacies of VQ mismatch versus shunt are always very difficult for me, but I would probably go ahead and go with VQ mismatch at this point and see where that takes us.
All right. Dr. Albert, looks like you have something to say.
Well, I'll make 2 quick points. The first is Anemia does not cause hypoxia. However, if you have hypoxia from low VQ or from shunt, anemia can make it worse because there'll be more extraction, mixed venous O2 will be lower, and in the setting of low VQ or shunt, arterial O2 will fall, okay? Second point is, it's a bit of trying to be perhaps too specific, but I think it's important for physiologic understanding. Rather than saying VQ mismatch, that can be high VQ or low VQ. That's still mismatch. But high VQ does not cause hypoxia. Only low VQ causes hypoxia. That is perfusion out of proportion to ventilation. All right, low VQ. If you have ventilation out of proportion to, if you have high ventilation, you won't get hypoxic.
Awesome.
So one more point. We know this is a VQ problem or potentially a diffusion problem, but it's not diffusion because on oxygen, the guy gets better. If it were shunt, a couple of liters of oxygen isn't going to do anything for his SpO2.
Excellent. Dr. Albert, thank you. So that's the benefit of having an expert clinician around. So with that being said, you guys have done a fantastic job. You're funneling into hypoxia, sort of those causes. Julia's given her approach, Jake's approach. We've combined those. So let's get into some past medical history and give some context like Yunan was interested in. So past medical history. This gentleman has had 2 TIAs, one in 2009 and the second in 2019. Following his second TIA, he says he had a complete workup for cryptogenic stroke or stroke of unknown etiology. And we reviewed the records, and the record said that he had a TTE in 2019 with no evidence of shunt on a bubble study and no thrombus. He also has atrial fibrillation, which was diagnosed via loop recorder, which is an implanted device which captures the rhythm. He's on chronic anticoagulation with Eliquis. He reports 100% compliance. He also has hypertension, and he has extremely well-controlled GERD. Let's get right into the social history as well here. So this gentleman was a long-term resident of Albuquerque, New Mexico, which is an elevation of 5,000 feet, so fairly similar to Denver. He moved here to live with his daughter in Denver in January of 2020, so about 9 months prior to presentation. And then you'll take my word for it. He's a never smoker, no alcohol, and has literally no relevant exposures. There is not a bird hiding somewhere in his house. And then in terms of medications, we'll get into that. He's on a Pixaban 5 BID. He's 100% compliant. That is an age and renal appropriate dose. He's on lisinopril HCTZ combo pill, omeprazole, and simvastatin. All right, so I'm going to let Snehad zoom out a little bit so we can take in everything and throw it back to the discussants.
I guess I can start. So, I mean, big takeaway here, I think we don't see pre-existing lung disease, but we do see pre-existing heart disease. So we have another possible kind of risk factor already for dyspnea, hypoxemia. You know, like, you know, I was saying that like whoever did the history, a great job because this is 90% of the workup immediately. So we don't have exposure history. We have an inciting event, but we don't have anything new really to add in. And the only other thing I'd say is, you know, being on anticoagulation with a history of AFib, consider DAH, but like so still low on the differential given the history.
I think the part of the history that I want to elucidate more is why was he treated for a possible pneumonia? Like what led the clinician to think that, kind of the clinical reasoning behind that, because I think that could show us or elucidate something else.
Yeah, good question. I could fill that in. So he had a CT scan ordered in the outpatient setting, which showed a right lower lobe consolidation. His PCP thought that was the most likely explanation at the time and gave him a 5-day course of Levaquin and azithromycin. He felt fine prior to the antibiotics, felt fine after the antibiotics.
So it was more just based on imaging findings rather than just the, okay, gotcha.
Yep.
And does he have any family history of anything?
Nope, he is a 86-year-old man who has actually a remarkably unremarkable family history.
And Danny, one other question. So I know you said he doesn't have shortness of breath when he was like lying down. Does he have it when he's sitting up then?
Yeah, great question. So on further questioning, he says that he does notice that when he goes from waking up in the morning and lying flat to sitting on the edge of his bed, he is more short of breath. He also tells you that when he's at home with his home pulse oximeter, he does notice that he's sort of low to high or mid to high 80s when sitting upright. But when he has his pulse oximeter on at night in his bed, he's setting low to mid 90s.
Yeah, so I think the thing just to take away from there, like what Julia was talking about with working through your lung architecture and finding a cause of dyspnea is like for vascular causes, you know, when you hear that sitting up and getting worse, the only thing that comes to my mind, at least, is hepatopulmonary. So no history of that, unlikely, but still something to consider.
And Jake, I think that's an awesome finding. So what drew you to the hepatopulmonary question there? Like what do you call that physical exam finding that you just hit on?
So it's either platypnea or orthodeoxia, depending on what you're looking at.
Awesome. And then Evan, one of our other interns, hit the same thing right in the chat. So Jake hits on a good point. So there are some clinical clues here that this man may have platypnea and may have orthodeoxia. Wonderful.
And other than not having like a thrombus or a PFO on the TTE, was there anything else on there, like any regurg or stenosis?
Yeah, great question. There are no valvular abnormalities commented on in the TTE. All of his functions are normal, and he has no elevated RV pressures. And that was from 2019.
Danny, was that done with bubbles?
It was. The report said it was done with bubble. We could not look at the images ourselves. All right. So I think everyone at this point, you guys have done an absolutely fantastic job. You are steps ahead of where we were as a team in person. And so wonderful. So I think with that, let's go ahead and get into the vitals and sort of the meat of this, because I think everyone wants to see some vitals and a chest x-ray. So let's talk about this guy's ED course. So these are his initial ED vitals on presentation. He's afebrile at 36.6. Heart rate is 93, blood pressure is 131/82, and he's setting 84% on ambient air. He gets 3 liters per minute and he bumps up to 91%. These are his initial vitals, but he sits in the ED for about 6 to 8 hours while waiting for a bed in our hospital. And here's a screenshot of his vitals while he is sitting in the ED. And so I'll give our discussants a second to look through these vitals here. For people that are not familiar with EPIC, the blue numbers at the top are the time of day and military time. SpO2 is his SAT, O2 status is if we're giving him oxygen, and the HHF stands for heated high flow, and oxy-M is oximizer. And so I will say as a qualifier to this, that during this period, he was asymptomatic and no intervention was performed. So discussants, what do you guys think about these vitals?
I think you're muted, Julia.
My first observation is that it looks like he got worse with more oxygenation, maybe like having heat high flow at 60 liters per minute is, I don't know, and his like oxygenation really didn't change, like didn't go much above 90. So I think that's interesting.
And it's also interesting, like with the heat at high flow, you get a little bit of PEEP. So I don't know if that has anything to do with his lower oxygenation, but that's consideration.
Good for you. Expand on that a little bit. Why would a little bit of PEEP change things in that direction?
So totally not sure if I'm saying like explaining this correctly, but the idea is like with a little bit of PEEP, you open up airways, perhaps in areas of the lung that you're, maybe like worsening the VQ mismatch. If those areas of the lung, for example, are consolidated or damaged, there's fluid in there.
Well, the PEEP will certainly expand lung. It doesn't really tell you what happens to alveolar ventilation, but presumably it would improve. And that shouldn't worsen your oxygenation.
I think you've got your answer in the chat there, Rick, actually.
Oh,
somebody
I didn't
in the chat
see
mentions
it.
the West zones.
Oh, that don't get me started on West zones. What does it say? Causes a shift in West zones. It could do that, but more generally, If you inflate the lung, you're going to dilate vessels that are in that area of lung that dilates. So you could be increasing perfusion to areas that aren't ventilating very well by using PEEP. And that's one of the, you mentioned hepatopulmonary as the etiology for the orthodeoxia, but there's a couple of other possibilities. One of which is an arterial venous malformation that will get bigger when you inflate the lung, and there'll be more flow through that AVM at a higher alveolar volume. And there's some others as well, but let's just leave it at that.
Perfect. So Julie, I wanted to go back to one thing you said. You said that it looked like he didn't correct or he didn't get better. And so I think you guys are all 2 steps ahead of this, but just so we can all be on the same page. How does his response to oxygen affect your differential here?
Are you asking me or the residents?
No, I'm asking the Julia, our intern.
Okay,
You're
good.
welcome, Dr. Albert. You're welcome to answer.
No, I was just curious who you were talking to.
Yeah, so I think if it doesn't correct and you're giving them like adequate oxygenation, that means that something isn't connecting, which I would think in this case would be that I'm sorry, I'm trying to put it together. It sounds like oxygenation is not the problem. I think it's perfusion. Would that make sense? Because perfusion would mean that like more, if we're perfusing these areas that aren't like the AVM or the, that could cause that. I don't know, sorry, I'm not making sense.
No, you're doing great. You're hitting on it, but you missed the one word. So you're saying that we're oxygenating things that we're not perfusing. And so essentially what you're talking about is there's a shunt there. So there is blood crossing from the right side to the left side of the heart. So whether it's going through the lungs or just the heart, it's not picking up oxygen. And so that vital trend, like you hit on right at first, is pretty consistent with shunt physiology. So you're giving this person oxygen, but no matter how much oxygen you give, they don't get above a certain level, which is awesome. And so like you said initially, if you're in the ED and you're looking at that vital trend and you see it doesn't correct, you can maybe say this person has shunt physiology. And if it does correct, that's when you talk about sort of the rest of the causes of hypoxia that Jake mentioned. And that's sort of a really easy way to break it down when you're standing at the patient's bedside and titrating oxygen. So awesome job.
And Danny, I'll even just take that a little bit further, which is to say that these are the hallmarks of each of those conditions. And so not correcting with oxygen is one of the things that defines a shunt outside of actually doing studies. And that the other thing is that the two usually or very frequently live together. And so where you find areas of VQ mismatch, you may find shunt and vice versa. So the fact that you don't see a pure response, that the person was 84 and they got oxygen, they got somewhat better, is not surprising that there'd be a little bit of both.
Yeah, you said you have trouble with VQ and with low VQ. One way to think of it that makes it really pretty simple is that shunt is the epitome of low VQ. It's just low VQ carried to the extreme, no perfusion, or rather no ventilation. Whereas low VQ is just a little less. So it's all the same problem, and they do run together. It's also interesting that within minutes over that time frame, he goes from shunt to primarily low VQ. And now you have a real clue as to what things are going to change the physiology that rapidly with no intervention or limited intervention or taking away an intervention.
Excellent. All right. So with that, let's get back to the case. Let me go back to the track one here. All right. So in addition, being the excellent intern that you are, you're also at the bedside and you check one more thing. You see that he's sitting 91% on 4 liters per minute sitting upright. And then when he goes to the supine position, he goes to 97%. And so Jake, talk to me about that finding.
Yeah, I think it just supports what we had already discussed. That's the orthodeoxia that co-intern Evan Zare had put in the chat a little while ago. And I think just like Dr. Albert and Julia and Yunan were saying, this kind of takes us back to AVM versus hepatopulmonary. I'm not sure about orthodeoxia with AVM, but the further we go down this case, the more that seems like something I should know about.
Perfect. All right. So let's give you a physical exam now. So in your physical exam, he's well appearing, no acute distress. He's got a regular rate and rhythm. His cardiovascular exam is essentially unremarkable. On his pulmonary exam, he's breathing comfortably on 4 liters. He has dry crackles throughout the posterior lung fields and crackles that are greatest at his bilateral bases, right greater than left. The remainder of his exam is unremarkable. Any brief thoughts on the physical exam from our discussants?
I think the one thing it kind of keys us into is, dry crackles, no JVP, no peripheral edema. Like, this does not seem like someone that I would immediately say is overloaded based on exam, which is, has to always be one of our highest things on the differential for dyspnea and hypoxemia. The other thing that's a little odd is if you have hepatopulmonary syndrome without peripheral edema, without no note of ascites either, it's, again, I think a little further on the differential than maybe AVM.
And I think it's also kind of like it points more towards a lung pathology just because there are no other abnormal findings on this exam.
That's great. I love it. So let's do this. So because you guys now have vitals, you've got an exam, I'm going to throw it back to Sneha, and I want you guys to take about 10 seconds and put together a problem representation and a really brief differential before we see this man's imaging. So a brave volunteer, I'll say Julia or Jake, which one of you guys wants to give me the problem representation?
I can do the problem representation. So this is an 86-year-old male with no known lung or heart pathology who's presenting with hypoxia for the past 2 to 3 months. Yeah, I think that's like the simplest form of it.
Great. And even going a step further, Julia, based on everything you guys have done so well so far, what are you cluing in on? Like, what can you end that problem representation with to help guide next steps?
Based on physical exam findings of orthodexia, concern for a shunt process versus a VQ mismatch.
That's great. Yeah, love that. And Sneha's done a fantastic job of recording your guys' differential sort of in real time. And so right now it looks like we're thinking shunt, whether it's an AV versus other. We've talked about hepatopulmonary. Anything else you guys would like to include on that differential before we talk about what sort of imaging studies we want?
ILD.
Yeah, I think given the basilar dry crackles, which is kind of your classic ILD finding without wheezes, that's smart to include.
Mm-hmm.
Guys, I missed this. I apologize. What was his smoking history?
He is a never smoker.
Okay, thank you.
Quick questions. I also had a clarification for his. So it sounds like he was an engineer. Did he have any, like, I know. Was he working in old buildings? Was he actually?
Great question. So he, it was not the planning and design section of it. He said that he basically has never lived in a house with asbestos exposure as far as he knows, or any other sort of environmental exposure. All right, so you guys are absolutely just killing us right now. So let's go ahead and get back and let's talk about his imaging.
About time.
I was trying to delay it as long as possible. All right, so here's his chest X-ray. I'll tell you guys right now, this thing right here is his loop recorder, just to avoid any uncertainty there. Okay. If one of my 3 discussants could volunteer to give me their focused read of this chest X-ray.
I can go for it. So focused, his airway looks maybe a little bit pushed to the right. I guess not like crazy. So he's got bones.
Everybody has bones.
His cardio. I mean, I've never spotted a fracture in the history, man. his cardiovascular silhouette is kind of obscured because the diaphragms are riding so high, but doesn't look particularly abnormal. Biggest thing might be that right diaphragm is like really high up there. So, was there volume loss down there? And it's tough to say how crisp that costophrenic angle is over there on the right in particular. Maybe there's a little fluid there, but I think I can kind of make it out. Other than that, the lung fields themselves look pretty good. Nothing focal that I'm really seeing right now.
Jake, that was a phenomenal read. Really, really nicely done. Dr. Albert and Dr. Connors, any additional thoughts?
If you want to go first. Oh, okay. I will say, it's going to be hard to read the bases of these lungs because of the low lung volumes. There's going to be some compression. There's going to be some atelectasis. As you pointed out, that right costophrenic angle is blurred. I would say that airway, Jake, like you pointed out, is significantly moved to the side. And then that becomes a simple push-pull question, right? Is there something on the left pushing it over or the right pulling it? And I think the volume loss is a pretty easy explanation unless you surprise yourself in some other way. And the only other thing I see is it just looks like he's got in addition to the high riding hemidiaphragm, it looks like his colon is up right under the diaphragm. So whether he's got the Chilaiditi syndrome. Thank you. I guess he, by definition, would have that. And so that is probably not relevant to the case, but it is present.
Yeah, that's the point I was going to raise, was that he does have an elevated right hemidiaphragm, and presumably it's paralyzed. Could be the result of atelectasis, but the shape suggests more paralysis. But you can see the colon underneath it with the stria. Sometimes the air in the colon underneath the diaphragm can look like an air fluid level. And that's where you need to know about Chilaiditi syndrome, because you don't want to assume an air in the peritoneum. It's just the colon in between the liver and the diaphragm.
Awesome. And I think one of our applicants asked, is there a reason he got a portable chest x-ray? The reason for that was he was on heated high flow at this time. And the ED was afraid about transporting. So
I would say one more thing. The airway, the trachea is certainly being pushed to the right. And I agree it could be a result of atelectasis, but when you get old like he is, the aorta is really stiff. And as you can see, it's even a little dilated there. And my guess is it's just being pushed over because of a stiff aorta. I don't think this is being pulled over. Usually when you get a trachea pulled over to the side of a collapse, it's an upper lobe collapse, not lower lobe. And I don't see any signs of upper lobe collapse there. But you do see, look at the difference in the rib interfaces, how the left side is more, there's more distance between the ribs than in the right side. The right side is, they're kind of pushed together a little bit. That could be due to rotation, but it could also be to collapse of a lobe.
Wonderful.
Hey, Rick, what do you think? Oh, sorry, Dan. Rick, what do you think about the position of the carina? I mean, I sort of.
It's right in the middle, I think.
Do you think so? Do you think with the rotation it's still in the middle? Okay.
I think it's in the middle, yeah.
Fair enough.
I do think there might be a little splaying of the carina. I think it's more than 90 degrees.
Mm-hmm.
That was incredible. So between Jake and our experts, that was amazing. So this gentleman has this ABG, which I'll let you guys look at, but essentially it proves that he's hypoxic on heated high flow nasal cannula. And then you guys are correct. He actually does have the Chilaiditi sign, which Dr. Connors and Dr. Albert both brought up. And so what is that? That is interposition of the colon between the diaphragm and liver. And if you don't know what you're looking for, it can look like free air under the right hemidiaphragm. And that essentially occurs because either the space gets larger or the liver gets smaller. And so a more dramatic example of that is here. This was a gentleman at the VA from when I was an intern who has the Chilaiditi sign as well. And so a really nice job. So the official right hemidiaphragm, considering some volume loss on the right side, and then like Dr. Albert said, a tortuous thoracic aorta. All right, so for our discussants, this is a choose your next step. You guys have hit on some stuff that you're concerned this could be ILD, but you've also talked about whether this could be a shunt. And so for our discussants, would you rather have a CT-ILD next or a TTE with bubble?
I think I'm going to go for the CT-ILD since he had a TTE a year ago.
I think I like CTs better because I can actually give some poor man's attempt at reading them versus TTs with bubbles. But I think I would prefer the TTE with bubble just because this doesn't scream ILD to me right now.
Julia, we're going to put you in the tough position of breaking the tie.
I think I would agree with TTE with bubble. Something just seems off, and I agree that it doesn't sound like a straightforward lung pathology.
Perfect.
Let me see if the people want to revote, learning one more additional piece of information. There's a very rare entity where you can get a right to left shunt that's positional. You only see it when you're upright. You don't see it when you're supine, and it has to do with the way the blood from the IVC streams into the right atrium. If it streams a certain way, it can open the shunt or give you a right to left shunt, and it's on the list of differential diagnosis for orthodeoxia. But if you're going to do the bubble study, you need to do it in the upright position, as opposed to the supine position.
Dr. Albert, you are in luck. We have got a supine and upright TTE bubble. All right, so this is a TTE. This is a comment here. So left ventricular function within normal limits, right ventricular size normal with grossly normal RV function. Estimation of his right ventricular systolic pressure is not possible due to absence of TR. So for our applicants, this means that his right ventricular pressures are likely within the normal range. His aortic root is injection of agitated saline documents a large right to left interatrial shunt consistent with a PFO. You get this TTE, and cardiology immediately tells you that he needs a TEE while inpatient. And here is his TTE image. And the red marks are showing what chamber you're looking at. LA is left atrium, LV is left ventricle, AV is aortic valve, and RA is right atrium. So unless you are really good at TEE, which I am not, I can tell you right now that this is not where it's not something you should typically see. So the next thing they do is they perform a bubble study in the upright position. So what you're looking at is an aneurysmal intraatrial septum with a tunnel PFO. An injection of agitated saline documents a large right to left interatrial shunt. Any questions from our discussants about this finding?
I think just one point to make, Danny, hey, this is Mark Kearns, is that keep in mind the bubble study, like the timing of when the bubbles transition from the right to left, if you don't have a TEE is very helpful. So if it happens within 1 to 2 cardiac cycles, you're thinking about an intracardiac cause. But we talked a lot about hepatopulmonary or AVM. So if you're seeing it in sort of the 4th through 6th beat after the bubbles go into the right atrium, that makes you think about intrapulmonary vascular causes of shunt.
Awesome. Thank you, Dr. Kearns. Dr. Kearns is one of our APDs and one of our pulmonary and critical care doctors at Denver Health. All right.
Danny, getting at what Rick was describing earlier, it's kind of funny because the first thing you're going to do with a patient in the echo lab, especially if they're an outpatient, is you're going to get them in a position where they sat well. Like the last thing you're going to do is leave them in the 80s to do the study, and it's the only way to make the diagnosis. And so this often becomes an in-hospital diagnosis, although it doesn't have to be, just because it's one of the few places people can tolerate that for even a few minutes.
Awesome. I actually did not even think about that. That's incredible. That's good. This is why this all happened inpatient. And I should say a huge shout out to Katie Yamamura, one of our interns who pushed incredibly hard and advocated for this gentleman to get almost all of this done inpatient. So she did an incredible job. All right, I'm gonna go ahead and show you guys the CT-ILD. These are the inspiratory images for the sake of time. We're scrolling down and I will replay these. All right. So in the interest of time, because we have pulmonologists on the call, I will go ahead and just ask for their take on the CT.
Well, he does have clear findings, although mild, of peripheral fibrosis, pleural based with some tenting, consistent with IPF. But he also has this area in the right lower lobe that's got honeycombing and collapse. So he does have ILD, but that's not going to give you variable oxygenation. That area in the right lower lobe could actually, as you change perfusion as per the effects of gravity.
Excellent.
Yeah, I agree. I think that's dense enough to do it. The reticulation you see is if you look, if you're not familiar with reading these, is look as Danny rolls down at right along the subpleural spaces, you'll see all that fine linear nature. There's also some ground glass. And then I agree with Rick. I think the defining feature, the defining thing that's making him as sick as he is what's going on in that right lower lobe. There's probably even some bronchiectasis there.
So that's exactly what they read it as. And then they also called likely UIP pattern, though mild. And so just as a reminder what our UIP pattern is, usual interstitial pneumonia. It's honeycombing and traction bronchiectasis. You need a reticular abnormality, so that fine net-like structure that Dr. Connors was talking about, typically subpleural and basilar predominant at the bases, and you need to sort of not have an alternative diagnosis. So at this point, I wanted to
go up a couple of cuts.
You did a pulmonary case with 3 pulmonologists on here.
Yeah, that's bad. Couple more cuts. All right, right there. Go back down. Look in the right lower lobe at the lines, the short lines that are perpendicular to the pleura. A little higher, right? A little higher. Well, all the way along that. That's what we're talking about. And you see how the pleura is indented a little bit? That's traction bronchiectasis, or traction due to the interstitial fibrosis. So that's the classical reticular problems that you see with UIP.
Excellent. So what I'm going to do now is I'm going to throw it back to Sneha so we can put the case back up and give everyone a second just to re-look over that again. Remind everyone sort of where we came from. And then I'm going to ask our discussants to give me sort of what their top 2 leading differentials are right now. How do you explain this man's hypoxia with the studies that we know about? And what do we think is going on?
I can start again. So I think we have our 2 differential diagnoses already in front of us. We have our ILD and we have a patent PFO with shunt. In terms of what's causing the dyspnea, the hypoxemia, I'd be inclined to, I don't know about severity of PFOs, but it looked pretty significant based on that bubble study. And in terms of ILD, like our esteemed pulmonary colleagues pointed out, like it doesn't look from a IPF standpoint that I've seen particularly heinous, even though it's a terrible diagnosis to receive. It's an acute presentation. I'd favor the PFO causing these symptoms.
Julia, any thoughts? Jake did a fantastic job. Any thoughts before we get the diagnostic study?
Yeah, I would agree that the PFO sounds like it's causing it. I mean, that was significant movement of bubbles across the atria. I can even see it as an intern. So I think that's most likely, and that's probably what I would pursue for management first, especially with ILD and treatments being limited. I think you have to pursue that first too, as like a management option.
Fantastic. So I think one of the best things you guys just did there was you consider the patient, you consider what we found out, and you know he has hypoxia, but his hypoxia is not correcting with a lot of oxygen. And so knowing those few things, you're focusing on this being the PFO, which shouldn't correct, whereas with his mild degree of ILD, perhaps we'd be able to get him a little bit higher than 91% with all that oxygen. So I think that's just a phenomenal way to think through that problem. So back to the case here. A CTPE is obtained because of another sort of clinical decompensation in which the patient's oxygen increases without any change in his symptoms. And I will play the CTPE right now. I'll tell you that he does not have a pulmonary embolism, but he does have another finding. All right, I'll play the second half of that one more time. And then this is subtle, and I will admittedly say was not picked up by our team until an attending radiologist caught it.
Is it something going on in the aorta?
Perfect. So that's one of two abnormalities, that the aorta is dilated at the root and in the ascending portion. And there's one other thing. Do our other discussants
Right
have
there. Yeah. Off the right main stem. Yeah.
Jake or Yunan, any other thoughts?
No, I'm gonna toss this one to Yunan or Dr. Albert for sure.
I may also toss this to Dr. Albert.
Or toss it to Melanie Weingart. She's got it.
So Melanie, there is no AVM in a shocking turn of events. There's no AVM.
No
That's
AVM.
wonderful thought. I'll tell you the official read here is asymmetric right hemidiaphragm elevation contributes to severe compression of the right atrium. So what are we looking at? So this is a slice that we just saw. That's the diaphragm, and that is the right atrium. So that's thin piece right there. Other structures that we have on here, we have his RV, his aorta, which Julia correctly found, and his left atrium. So just as a reminder, what does normal look like? So that's what your normal right atrium looks like without an elevated right hemidiaphragm. It's obviously significantly larger, it's not compressed, and it looks better. So even more impressive, here's a frontal shot of that same CT scan. That's the diaphragm, that's the aorta, and that is the right atrium. So you can see on this CT scan that his right atrium is essentially basically compressed into nothing between an elevated right hemidiaphragm, which Jake initially picked up on the first chest x-ray, and Julia correctly called an aorta, which is dilated and compressing down. And as a reminder, that's what normal looks like.
And Danny, I guess the only thing I'll add is like what's so interesting about this case now is it takes us back to that issue of PEEP originally, of why PEEP might have hurt this gentleman too. I don't know if like 5 of PEEP will really, decrease your venous filling, but it's super interesting.
Absolutely, I love it, Jake. That is a great thing to pick up on. All right. So at this point, a couple things going on. How do you guys want to evaluate this diaphragm? They've called severe right atrial compression by the diaphragm. How do we evaluate the diaphragm? It's not something we do often.
I called Dr. Albert.
No, that's not hard. Have you heard of a sniff test?
I've heard rumors of it.
All right, so you're just looking. You put them under fluoro, and you have patients abruptly sniff in, and when there's a paralyzed hemidiaphragm, when you sniff, the paralyzed diaphragm goes up and the other diaphragm goes down.
So to replay this, Dr. Albert just said it perfectly. This is the right hemidiaphragm, this is the left. When the patient sniffs, the left drops, but the right does not move. And so interestingly enough, minimal excursion of the right hemidiaphragm, but no paradoxical movement, which is actually consistent with a diagnosis called eventration.
Eventration, yeah.
So what is eventration? This is probably something you guys have all seen on numerous chest x-rays, but you haven't actually thought about too hard, or at least I hadn't. So this is our patient's chest x-ray with the elevated right hemidiaphragm. And here are some examples of eventration from my time as a resident. So that right there is the eventrated portion, or it's a weakening and sort of a fibrous replacement of the diaphragm and a ballooning. There's another example, this lumpy, bumpy diaphragm appearance. And then another example here with sort of another lumpy-ish diaphragm appearance. And so all of that is consistent with diaphragmatic eventration. And so ultimately this gentleman, we consulted thoracic surgery about the diaphragm and cardiology about the PFO, and cardiology and thoracic surgery recommended PFO closure with an occlusion device. And so here is a CT scan showing his PFO occlusion device and a little bit of expansion of his right atrium after that's completed. So within 15 minutes of the procedure being completed, this patient was weaned back to room air and was able to ambulate on room air without any sort of hypoxia. And so our ultimate diagnosis in this case, which you guys correctly called, is the Platypnea orthodeoxia syndrome due to a large right to left interatrial shunt via PFO due to severe compression of the RA by a right hemidiaphragm eventration and a dilated ascending aorta. And so for a really quick 2 minutes here, or 3 minutes, I just wanted to talk quickly about the Platypnea orthodeoxia syndrome, because I think it's something that we don't see too often. So I apologize for the acronym, but just so I don't have to spell it all out. So what is the Platypnea orthodeoxia syndrome? And so essentially what it is it's platypnea and orthodeoxia. And so how do we diagnose that? And so you diagnose it with a PaO2 that drops by greater than 4, or an SaO2 that drops by greater than 5% when you go from the recumbent to the supine or the upright position. And then it corrects when you change your position. So when you go sitting upright back to supine. And so what are the causes of the Platypnea orthodeoxia syndrome? And so there's really two big ones. There's your cardiac causes, and then there's your pulmonary causes, my cartoon lungs here. And so when you're talking about cardiac causes, the two biggest ones are, a PFO and an ASD. But that by itself is actually not enough to get the Platypnea orthodeoxia syndrome. You also need something which is basically compressing the RA. And so Dr. Albert, being the expert that he is, actually called this about halfway through the conference as one of the rare causes. But when you're thinking about things that compress the RA, you basically need to have sort of a diaphragm issue or an aortic issue. And whether that happens via surgery or idiopathic in our case, you need to have one of those two things compressing the RA to then basically funnel blood through that PFO. Because as a reminder, this man had normal RA pressures. So he had no reason to have this shunt outside of those anatomic abnormalities. And then the thing you guys did excellent during this conference was talking about pulmonary things. You hit on it: AVM, hepatopulmonary syndrome, or anything which increases your RVSP can kind of push you back toward this direction. And so when you're talking about Platypnea orthodeoxia, the treatment is to fix the heart. And so if you fix the heart and you close that PFO, oftentimes people can do just fine, like in this gentleman's case, with their existing abnormalities. And so our gentleman is following up in our pulmonary clinic here for his ILD. He's going to get PFTs done and have that fully worked up. And then he's going to have a repeat CT scan to look at that right lower lobe consolidation in about a month, because there is some concern that he may have an atypical infection or a malignancy, given that it has not changed. Any thoughts from our discussants about this case? You guys did absolutely.
Hey, Danny, I have a question. Present prior to like the compression happening, and it just like enlarged, like got bigger with like the anatomic problems that he had going on, or was it like something that was completely caused? Like there was no PFO like earlier in his life, and it like, do we know?
Yeah, Julie, good question. Our best guess is that this gentleman has had a PFO most of his life, but he never had to the degree one of these things to pop it open. And so with age, your aortic root actually gets slightly larger. And with age, your eventration actually gets slightly worse, because it's basically a muscular issue, and your muscles break down and the ballooning gets worse. And so our best guess is he basically hit a critical point where both of those structures came together and popped his PFO open.
Yeah, I guess the only question I have is kind of echoing what I think one of our, I think applicants, Megan Marshall, was asking, which is why did he have this eventration in the first place? Was it secondary to the presumed IPF? Like, is that a precipitating event, or?
Yeah, so the eventration is often idiopathic. You can be born with eventration, but it's often idiopathic and due to age. When you're talking about things like paralysis, you get into polio and viral infections and cervical issues and trauma. But this gentleman, as far as we know, didn't have an inciting cause. But I'd be interested to hear.
I actually think that we haven't excluded a paralyzed hemidiaphragm. I would favor that diagnosis over the eventration, And I would for a couple of reasons. The first is the shape of the diaphragm is really quite different than what you see with eventrations. It usually doesn't involve the entire diaphragm itself, but just a portion of the diaphragm. Secondly, the reason that the diaphragm might not have moved up with the sniff test is that it was already up a lot. And there's a limit to how much the diaphragm can move up with a sniff test. So I don't think we've excluded paralysis. On the other hand, I don't think it matters. It's not clinically important to make that distinction. There is a different differential. Everybody always worries about a proximal cancer pressing on the nerves, but I've never seen that in 45 years. So I don't think it's important to separate the two. But I think it's much more, the picture of it is much more consistent with a paralyzed hemidiaphragm.
Danny, just a quick, this is more for my curiosity. Would this gentleman be pretty like preload sensitive if like someone had diuresed him with how compressed his RA was?
Good question. So we never asked that question. What we did ask was if we were to close his PFO to thoracic surgery, would we put him into like an obstructive shock picture? And thoracic surgery felt that closure of the PFO would probably not hurt him. It would probably actually fix him. Like, you'd be able to build up enough back pressure to still fill, which ended up being the case. But it's a good question. We did not ask that, but it's definitely something that I would have in the back of your mind.
There's a question from
Excellent.
Ace, which is, why does platypnea happen? Danny, I don't know if you want to answer that. It's on the chat.
Yeah, absolutely. So Jonathan's asking about platypnea. And so there's the pulmonary version of platypnea, and then there's the cardiac version of platypnea. So the pulmonary version, if you have an AVM here or here, when you are in the upright position, your blood flow will preferentially go through these areas based on gravity. And so then when you lay back down, you go supine, that blood flow equilibrates better, and you decrease the proportion of your blood flow which is crossing through the lungs. And so when you're upright, you have more blood flowing through the bases, you get more blood going from the right side to the left side of the heart without getting oxygen, and that's what the platypnea comes from. For cardiac causes, if you have this is a horrible, horrible version of the heart, but if this is roughly your heart, and this is your PFO right here, if you just say, for instance, like your PFO is always taking 50% of your blood flow, like Yunan was saying, in the upright position, you actually have decreased venous return. And so you have basically less blood coming through the lungs and actually getting oxygenated. But when you lie down and you increase your venous return, if you imagine 50% of that blood is still going through the PFO, but if you now have 6 liters instead of 5 liters, you're getting 3 liters of blood oxygenated versus 2 liters of blood oxygenated in the upright position. And that's kind of an easy way to think about the cardiac version of platypnea. Hopefully that answered the question. It wasn't just rambling.
Danny, you should be an animator. Your drawings are incredible, honestly.
Yeah, they're good.
Or a pulmonary fellow next year. Either way.
I should tell you about the last patient I saw with orthodeoxia. 85-year-old guy whose chief complaint was that his bowling score had deteriorated. And he had an AVM in his left lower lobe that was the size of a grapefruit. And his saturation was like in the mid-50s. I thought the AVM was too large to coil, that he would get such a terrible necrosis that he'd have all kinds of cytokine storm and pulmonary abnormalities. But IR coiled him, and just like this case, the PO2 came right up immediately. He did absolutely fine, had no sequelae. I saw him a month after the procedure, and his bowling scores had returned to normal.
So with that, Dr. Albert, thank you so much for participating today and helping us out. I thought I was going to maybe stump you there for a second, and then you said the rare diagnosis halfway through. So another day. But yeah, thank you so much to Jake, Yunan, and Julia. You guys did an absolutely phenomenal job. As a reminder, Jake and Julia are interns. Yunan's a second year, and they are like basically already operating at the level of like very advanced residents. And so just a taste of what like sort of clinical training is like here and how we prepare people for that next step. It's been a blast hanging out with you guys. Hopefully the interview went well. And like we said earlier, if you guys have any questions, don't hesitate to reach out to your resident liaison from last night or to any of our chiefs. We're happy to answer questions throughout the interview process. So thank you, everyone.
Thanks, Danny.
Thanks, Danny. All the residents, thank you so much. That was great. Get to watch you all in action. And applicants, stick around here for a few more minutes. And for the Med Peats folks, I think you have to